Hello, everybody, and thank you very much for joining us. Today, we have a real authority on the subject. Dr. Michael Stewart from New York is the chair and professor at Cornell University. Michael, can you hear me?
Yes, yes.
That's good. Thank you very much for joining us. It's a real honor for us to have you here. Thank you for giving us the time.
So thank you very much for the invitation.
So everybody has been looking forward to hearing your talk. We have about 80 people already online. I think by the end of the meeting, we will have up to 300. There will be at the end. I would like you to give us like 10 minutes for questions on the chat line, as well as if somebody wants to come and speak to you on the microphone. But please go ahead. Go ahead and. You have the podium. Thank you again.
Great, thank you. And okay, have you got my slides there?
Absolutely.
Great. So I'm going to be talking about tips in revision sinus surgery. So first of all, we should talk about what are the indications for revision surgery. Obviously, if you have a complication of the original surgery, such as a CSF leak, that would be an indication for surgery. Recurrent infection or polyps might be an indication, but I think one thing I want to make the point of today is that sometimes, even though your surgery failed, the patient doesn't need more surgery. Maybe what they need is different medical treatment or better medical treatment. Certainly, another reason for revision surgery is if you have inadequate ventilation of the sinuses to allow topical medications. And then another indication is a neoplasm, which is either found on pathology, like an inverted papilloma or a carcinoma, or if you have obviously a recurrent neoplasm, that would be an indication for revision surgery. An important question to ask is the anatomy the problem? Because many times I've seen patients who've actually had adequate surgery. The sinuses are open and ventilated. They have recurrent polyps or they have persistent infection, but in fact, they don't need more surgery necessarily. Sometimes they do, of course, but sometimes the problem is that there's really a medical issue that has been not fully addressed. Another important question is the use of advanced technology like image guidance, and we'll talk about that. This is from a paper by Dr. Kountakis, Dr. Stylianos Kountakis at the University of Augusta in Georgia here in the United States. He's actually written textbooks on revision sinus surgery. I actually wrote a chapter in one of his, in a couple of versions of that textbook, and he's written a lot on this subject. This is from a paper that he wrote more than 15 years ago, but actually this has probably not changed that much. He identified the most common anatomic problems requiring revision surgery were lateralized middle turbinate, an incomplete anterior ethmoidectomy, scarring in the frontal recess, retained aggranase cell, an incomplete posterior ethmoidectomy, and a retained uncinate. And if you look, basically of these, of course, some patients have more than one anatomic problem, which is why these percentages add up to more than 100. But if you look here, the middle turbinate, the anterior ethmoid, and the uncinate put together would be the most common area. And then the second most common area would be the frontal recess. So this is really your most common anatomic problem that you're seeing that require revision surgery. There are other factors, though, that are non-anatomic that might require revision surgery. This is perhaps untreated allergy, perhaps smoking, perhaps aspirin intolerance, etc. So there are other conditions, under many circumstances, that will cause persistent or recurrent rhinosinusitis, and you don't want to make the mistake of just going back and trying to do more surgery, potentially even getting a complication from the surgery, if in fact the underlying problem was one of these. If the underlying problem was osteitis or untreated allergy or cystic fibrosis or ciliary dyskinesia, for example. So our understanding of chronic rhinosinusitis is really evolving. And we believe for many years that the vast majority of patients of chronic sinusitis actually simply had a prolonged case of acute sinusitis. So what happened was, you got osteal obstruction, which caused bacterial overgrowth inside the sinus. That changed the milieu, the environment inside the sinus, which caused ciliary dysfunction, which caused swelling, which caused obstruction, which kept the bacteria growing, and you got in this cycle. And if it lasted for more than 8 or 12 weeks, that was chronic rhinosinusitis. And in fact, that still occurs. That is still a mechanism for chronic rhinosinusitis. However, we understand now that many times the primary problem is fundamental mucosal disease, not osteal obstruction. It's an inflammatory disease of the lining of the nose and sinus, and not simply a plumbing problem or a ventilation problem at the ostia. And the point I was making earlier, recurrent mucosal disease inside the sinus does not always mean that the patient needs more surgery. If the sinus has been adequately opened and they have mucosal disease inside the sinus, perhaps what they need is different medical therapy. Perhaps what they need is topical and irrigation therapy. So this is the same thing said a different way. In some patients, improving the ventilation is not going to necessarily resolve the underlying mucosal inflammation, such as in patients who have eosinophilia or ciliary dysfunction or polyps. And in fact, there has been some movement back toward more radical surgery. Endoscopic surgery conceptually was considered to be less aggressive, less invasive. Instead of making large openings in the sinus, we were making small functional openings in the sinuses. And in many cases, that reestablishes mucociliary clearance, it reestablishes sinus ventilation, and that's what was needed. However, there are some patients who have enough mucosal disease that in fact what's needed is a mega antrostomy. What's actually needed is a very large opening to allow the patient to irrigate medications into their sinus and also to remove crusting and disease from inside the sinus. Similarly, in some patients, what's needed is a draft 3. What's needed is a more significantly aggressive opening of the sinus to allow drainage as opposed to just reopening the small hole again and again. Now, the problem is chronic rhinosinusitis is not one single disease. It may present in a similar way, but there's multiple different pathways which lead to this presentation. So just because some patients actually ultimately benefit from a draft 3 does not mean every patient needs a draft 3 at their initial surgery. Similarly, some patients need a large maxillary antrostomy, but not everyone does. And in fact, some patients may be harmed by making too large of an opening because the airflow into the sinus will cause ciliary dysfunction. So this is not what we call in the US one size fits all. But in fact, the concept of more radical surgery in some patients is probably appropriate. Having said all that, and basically making the case that failed surgery doesn't necessarily mean you need more surgery, you always have to think about, is there an underlying medical or other problem? In fact, there are still many reasons that patients need revision surgery. And in fact, there are multiple studies. This is just a few studies, but I could have found many more. There are multiple studies that show you can achieve good outcomes after revision surgery. In fact, some studies have showed the outcome improvement in quality of life after revision surgery is greater than the improvement after initial surgery. So if you believe that revision surgery is necessary, you should not think, well, the first surgery failed, so I'm sure the second surgery will fail. It's quite possible to get very good outcomes in revision surgery if you need to do it. So now we're going to talk about when you need to do revision surgery, what are the tips about how to do it? And I'll share some of my experience in a couple of videos and some basic concepts on this. So in my experience, the reasons for revision surgery, both my own revision surgery and when I'm doing revision surgery from other surgeons, the most common problems are with the uncinate process and the middle turbinate. That's what I have seen as the most common reason for revision surgery. Synechia are also a problem, but in many patients, you will see synechia between the middle turbinate and the lateral nasal wall, or between the middle turbinate and the septum, and the patient will have no problems from that. The presence of synechia does not mean that they need revision surgery. Synechia does not necessarily cause functional problems with the sinuses, but sometimes the synechia is the problem. And then in my experience, the frontal recess is not the most common reason for revision surgery, but it's not rare that the frontal recess is the area where you need to work. You definitely need to have a plan for what you'll address, and you don't need to go and do more. You don't need to open up unaffected areas. Sometimes, in fact, the previous surgeon or you yourself have done a very good job of opening most sinuses, and there's actually a fairly limited area. So revision surgery does not necessarily mean extensive surgery. It sometimes can be very, very targeted surgery, which almost seems like you should be doing more, but in fact, sometimes that's all you need is a very targeted area to revise. Your anatomic landmarks become extremely important in revision surgery because, of course, some of the anatomy has already been removed. And I believe that it's a good practice that as you do more revision surgery in your own practice, you will become a better primary surgeon. If you revise your own cases, you learn from the mistakes that you've made. And when you see the mistakes that other surgeons have made or the healing that some patients have, it actually helps your primary surgical technique. So I would say embrace revision surgery, be thoughtful and targeted, and try to avoid complications. But in fact, learning how to do good revision surgery will make you a better primary surgeon. So these are some anatomic tips. In revision surgery, a wide maxillary ostium is very important. Even if, in fact, the primary problem is not in the maxillary sinus, opening the maxillary ostium widely is helpful because it helps you locate several other anatomic landmarks. Most importantly, it shows you the plane or location, the sagittal plane of the lamina propria. If you open the maxillary ostium well, then in fact, going in a vertical sagittal plane, that's the level of the lamina propria, and you should not go lateral to that when you're operating inside the ethmoid. It also shows you the medial orbital floor. The medial orbital floor is very important because it shows you the level of the anterior ethmoid, and it also shows you the general level of the roof of the sphenoid sinus. So the sphenoid sinus tends to be inferior to the medial orbital floor. Finally, looking inside the maxillary sinus and looking at or using a suction or a probe to touch the depth of the posterior maxillary wall will show you the depth of the anterior face of the sphenoid. That is a remarkably consistent anatomic relationship. The posterior wall of the maxillary sinus is at the same coronal plane as the anterior face of the sphenoid sinus. Now, many of these anatomic tips are becoming lost on our trainees and lost in current practice because we have wide availability of image guidance in many parts of the world. Certainly in the United States we do. And people get very used to looking for these landmarks using image guidance. And I use image guidance and I like image guidance. The problem is sometimes the image guidance machine can be in error. Second of all, the image guidance machine may crash. It may not be available to you, or you may be working someplace that does not have one. So I think it's very important that sinus surgeons are very comfortable with some of these anatomic landmarks because you can't simply rely on image guidance to find everything for you, particularly when previous surgery has removed certain things, like, for example, the middle turbinate. The choana is a very important anatomic tip. No matter how much extensive surgery the patient has had, you can identify the choana. And then finally, the skull base, and the best place to find the skull base is in the posterior ethmoid. It is usually, the posterior ethmoid is usually one large cell as opposed to many smaller cells in the anterior ethmoid. And it's a great place to find the skull base safely and then trace the skull base anteriorly from the posterior ethmoid. This is a picture from a textbook by Dr. Casiano. This is looking in the left side of the nose. The septum would be over here. This is the maxillary ostium, and you can see in here the medial orbital floor. The medial orbital floor is generally going to be the roof of the sphenoid sinus. So the sphenoid sinus is going to be mostly inferior to the level of the medial orbital floor. This is the posterior ethmoid, which is going to be above the sphenoid for the most part. This is a demonstration of here's an uncinate, and here's an uncinate that's been removed. This is a unilateral maxillary antrostomy, but what this shows you is this shows you the fact that the maxillary ostium is in the same plane as the lamina propria. This is extremely helpful because I'm going to go back to this picture here. If you identify the maxillary ostia and then look at a vertical plane in the same, that tells you your lamina propria. You should not be operating in the ethmoid lateral to the level of the maxillary ostia. That keeps you out of trouble. Here's another example, and these are some sagittal scans, but I want you to look at the relationship between the anterior face of the sphenoid sinus and the posterior wall of the maxillary sinus. I'm going to scroll through the scans. Keep your eye on this vertical plane, and as we scroll through here, you'll see here's the plane. Scroll through, here's the plane, and here's the posterior wall of the maxillary sinus. I'll go back through that one more time. Here's the plane. Here it is. Here it is. There it was, and there it is. Here's the posterior wall of the maxillary sinus. So that is the same depth. If you're operating in the posterior ethmoid, and you're not sure if you're in a posterior ethmoid cell or in the sphenoid sinus, take your suction or a probe, go through your maxillary ostia, touch the posterior wall of the maxillary sinus, and then with that same depth, go into your ethmoid and see. If you're still inside the sinus at that point, you're not in your sphenoid yet, because that depth is the anterior face of the sphenoid sinus. Here's another example from another set of scans. Here's the anterior face of the sphenoid. Here it is, there it is, and there it is. The posterior wall of the maxillary sinus is the same depth as the anterior face of the sphenoid. Here's some other pictures showing some landmarks in revision surgery. This is the left side of the nose. This is the septum. This is the middle turbinate. This is the inferior turbinate. Here's the posterior ethmoid cavity, and the skull base is the roof of this posterior ethmoid cavity, which you could then trace anteriorly if you needed to. And here's the level of the lamina papricia at exactly the same level as the maxillary ostia. And here's the inferior turbinate. Here's another picture. This is also a left side. Here's the area of the ethmoid bulla, which has been removed. Here's the area of the basal lamella in gray, which has also been removed. Here's the maxillary ostium. Here's your medial orbital floor. Here's your sphenoid. There's your lamina papricia in this same plane. Here's your skull base in the roof of the posterior ethmoid sinus, which is the easiest place to find it. This is the level of the face of the sphenoid, which is the same level as the posterior wall of the maxillary sinus. And here's your sphenoid ostium. These are from the American Academy. These are the indications for image guidance in sinus surgery if you have image guidance available to you. And the number one indication for image guidance is revision surgery. And in my experience, I use image guidance in revision surgery pretty routinely. But even when I operate with image guidance, I never look at the image guidance first. I never use the image guidance to actually guide my surgery. I actually am looking at the endoscopic view of the anatomy, and then I glance at the image guidance screen, and I look at where the tip of the probe is or the instrument, and it's confirmatory. The image guidance confirms what the anatomy tells me, not the other way around. Other indications for image guidance are distorted anatomy, extensive polyposis, pathology involving the frontal, posterior ethmoid, sphenoid, etc. You can see those listed there. Neoplasms are also an indication. So in fact, it's very appropriate to use image guidance in revision surgery, but keep in mind that there are usually a few millimeters of error even with the best image guidance tool. Also, the farther away you get from the fiducial markers or from the probe, the electromagnetic probe, the farther away you get, the greater the error is. And so you should use your system to confirm the general area rather than actually pinpoint your exact location. If you think to yourself, I think that I'm touching the skull base, and you look at the image guidance, and the image guidance tells you, no, you've got 3 millimeters more to go, I would believe your eyes over the image guidance. I would not say, oh, well, the image guidance says I have 3 millimeters more to go, I'll just push through that. Because in fact, the image guidance can be off by 3 millimeters. It should really tell you the general area you're in, but not pinpoint your exact location. So here are some common problems that I have seen in revision surgery, two fairly common ones that can actually fool you a bit in the office if you're not careful about what you're looking for. So this is a patient who had surgery elsewhere, and his primary symptom was persistent postnasal drainage. He had had endoscopic sinus surgery by a good surgeon, but he reported that he had constant posterior drainage. And I actually looked and did endoscopy, and my initial impression when I did endoscopy was, actually, he had pretty good surgery. Looks like I can see into his maxillary. It looks like I can see his anterior. I can see into his ethmoid, although he does have some secretions in the maxillary sinus on the right side. But let me show you this image here. So this is a video. This is the right side of the nose. There's the middle turbinate. Going back in, there's the middle turbinate. What you can actually
somehow, Michael, we're not seeing the video.
The video's not there?
Mm.
Oh shoot. It's on my, let me see if I need to share it a different way. Let me see if I can.
Maybe it says optimized for video. Could that be the?
Are you seeing it now?
Yeah. Yes, absolutely.
Okay, I'll go back to the other screen in a minute. Thank you for telling me. So let me back up just a little bit. This is looking in the right side of the nose. There's the middle turbinate. And what you can appreciate now, and what I actually missed the first time I did it, but I realized that after I looked at his scans and looked back at my video, this patient still has an uncinate. This uncinate has not been removed. And in fact, the maxillary opening is too far posterior. You see where this maxillary, and you can see those secretions sitting in the maxillary sinus. So it's an adequate opening, but it's too far posterior. It's not the natural ostium. You can see here that the patient's had actually a nice ethmoidectomy, and there's limited disease in the ethmoid. Similarly, on the left side, here's your middle turbinate. And again, you've got a little crusting there, but you've got this residual uncinate that you have to look back posteriorly behind it to see into the maxillary opening, which is too far posterior. I think you can appreciate right there that this patient still has a lot of residual uncinate, even though if you put the scope in farther, you can see an opening into the maxillary sinus. Now let me go back to share screen. Okay, you back with my slides?
Absolutely.
All right. Okay. Now, this is that patient's CAT scan. And what you can see is that actually, here's the middle turbinate. Here's a pretty good ethmoidectomy. Here's some mucosal disease in the maxillary sinus on the right. The patient has residual Haller cells there, infraorbital ethmoid cells. There is residual unresected uncinate right here and right here. And then here's a residual Haller cell and some residual uncinate. There actually is an opening into the sinus, but the opening is too far posterior and it's not where the natural mucociliary clearance wants to go, which is why the patient has persistent mucosal thickening and mucus buildup in the maxillary sinus. This patient had an extremely easy revision surgery. All I did was went in and did a uncinectomy, basically, and I opened up these Haller cells. So it was a revision of the maxillary ostium by removing the Haller cell and removing the uncinate. I didn't touch the ethmoids, I didn't touch the frontal, and actually this patient's postnasal drainage resolved. And now when you look in the patient's nose with endoscopy, you can see that he has a nice large oval maxillary ostium in the correct location. Here again is a picture of, there's an opening, but that opening is too far posterior. Now, this is a lateralized middle turbinate. And what's interesting about this case is this is a patient who also had surgery elsewhere. I'm choosing to show you two patients that were revisions of other surgeons. I have had to revise my own surgery. I'm just not showing you any examples of that today. I don't get it perfect every time either. This is a lateralized middle turbinate. This is a patient who had surgery elsewhere and had really very persistent symptoms, frequent purulent drainage, infection. When you saw him when he was infected, the nose looked terrible. If you treated him medically, he looked better. But then when you actually did a scan, the scan showed a lot of mucosal disease. But what's interesting is here, look at the middle turbinates. The middle turbinates on this scan, to me, do not look that bad. He's got a lot of undissected ethmoid here anteriorly. Next cut, he's got mucosal disease here. But again, these middle turbinates don't look too abnormal, at least on the scan. He's got openings into his posterior ethmoids. In fact, his posterior ethmoids look better than his anterior ethmoids, but he still has a lot of mucosal disease in the maxillary sinus, and it's not clear that he's had a good uncinectomy on this side. Now I'm going to have to do my change again. Let me change my share screen so I'll show you the video. You seeing the video?
Yes.
Now, what's remarkable is, this is the patient's left side. Look at how dense that adhesion is between the middle turbinate and the lateral wall. The scan really does not demonstrate just how lateral this middle turbinate is and how much it's blocking any anterior ethmoid drainage. You can glimpse the maxillary ostium there, but in fact, this middle turbinate is completely plastered over into the lateral wall on the left side, which explains why he's having persistent infections. This is the right side, and it's even worse. Again, it's surprising to me that the endoscopy looks this bad because the scan didn't look that bad in terms of the middle turbinate. What the surgeon did in this, first of all, you can't see the maxillary ostium at all. What the surgeon actually did is he or she went through the middle turbinate to enter the posterior ethmoid. So actually, the posterior ethmoidectomy is not bad. And there's actually a sphenoid ostium you can see back there. There's a sphenoid ostium back there. But the anterior ethmoid and the maxillary ostia are not addressed at all because of a severely lateralized middle turbinate. Now, this was not a simple revision surgery, but in fact, this was a surgery that involved, let me switch back to my share screen here. This was a surgery that involved resecting part of the head of the middle turbinate because it was too lateralized and too scarred. I could not leave it intact. Doing a completion unsinectomy, particularly on the right side. The left side was better. And basically doing an anterior ethmoidectomy, which had really not been adequately performed. So this patient needed more revision surgery, but in fact, it was a fairly targeted revision surgery, targeted at the middle turbinate, the uncinate, and the anterior ethmoid. Farther back in the nose, the surgeon had actually opened the nose reasonably well. Takes it a minute to go forward here. Here we go. All right. So it's very important to perform a complete uncinectomy. Use your maxillary ostium and your medial orbital floor as landmarks in revision surgery. It's also very important to potentially do a septoplasty if necessary. There's actually some very good work by Dr. Tim Smith, and also some other work that's been done by others, including Zach Soler and Peter Wong, where they have looked at markers of success in revision surgery. And actually, a septoplasty, statistically doing a septoplasty in revision surgery, if it wasn't done the first time, actually statistically predicts better outcomes. So in some patients, probably a deviated septum, if it's not been fully addressed initially, is contributing to failures, probably because it prevents topical therapies from getting back into the sinus cavities like they should. So I have a low threshold for doing a septoplasty initially or doing a septoplasty in a revision surgery. If the patient has failed and it looks like the septum is okay, but not perfect, I will go ahead and do the septum with a revision surgery, because there's actually evidence that that patients who have a septoplasty will do better. So I would not be shy about doing that. I have also seen patients who have had no disease in the frontal sinus, who've had sinus surgery, and who have had a lot of work in the frontal sinus, who've then developed complications in the area of the frontal sinus. And the reason is because they have done too much surgery in a very narrow area, and it's created circumferential scarring. So if the frontal recess is draining, leave it alone. If, however, obviously the patient has obstruction of the frontal sinus, frontal sinusitis, a frontal mucocele, et cetera, then you have to operate in the frontal recess. But in general, this is an area which is best left alone because you're more likely to cause secondary problems. I think another important tip, and I actually did not learn this tip until I had been doing sinus surgery for a few years. And it's an important concept that the basal lamella is not just a vertical structure. The basal lamella, which is the anatomic boundary between the anterior and posterior ethmoid, the basal lamella, some people used to call it the ground lamella. The basal lamella is actually an attachment of the middle turbinate to the lamina propria, the lateral nasal wall. And also, it is an L-shaped. It's L-shaped, and there is a horizontal posterior portion of the basal lamella. In doing ethmoidectomy, total ethmoidectomy, it is sometimes very tempting, particularly with a microdebrider, to just remove all that bone and create a wide open cavity. And when you do that, if you remove that horizontal portion of the basal lamella, that actually is a bone that's holding the middle turbinate medial, and it can destabilize the middle turbinate and make the middle turbinate more likely to lateralize. Here's a sagittal drawing of the anterior ethmoid and posterior ethmoid, and this is a drawing of the basal lamella. The part we're used to seeing as we operate endoscopically back through the ethmoid is you're used to identifying this anterior face of the basal lamella. You open into this anterior face, and that exposes your posterior ethmoid. The temptation then is to continue to remove all this inferior portion, which can destabilize the middle turbinate. Here's another drawing. This is a coronal drawing of the left side of the nose. Here's the septum. Here is the middle turbinate. Here's the superior turbinate. And here is this horizontal portion of the middle turbinate, which is actually a strut holding the middle turbinate in place. As tempting as it is to remove this bone and make this look like one big cavity, you're better off leaving that bone because it prevents lateralization of that middle turbinate. Now, partial middle turbinectomy. This is a subject which is almost emotional or religious in some people's minds when it comes to endoscopic sinus surgery. Many people believe very strongly that it is important to preserve the entire middle turbinate for a few reasons. First of all, it is a landmark which is helpful in revision surgery. Second of all, there is some olfactory epithelium and some olfactory receptors on the middle turbinate. That is true. And it was also believed to be a very important functional aspect of humidification and also of sinus ventilation. And there were people who felt like it was almost a sin to remove any portion of the middle turbinate. You must preserve it. Well, I believe that the evidence is much more clear now after many years of sinus surgery and the experience of many different surgeons that in fact, you can partially remove some of the middle turbinate safely. You do not need a completely intact middle turbinate in every patient. It's not a good idea to completely remove the middle turbinate routinely. You don't need to. And in fact, it can create some olfactory dysfunction, and it can even create some lateralization of the stump of the middle turbinate, which can block the frontal recess. So I believe in preserving the middle turbinate. I think I try to preserve it every time. However, if the middle turbinate is extremely diseased by polypoid degeneration, if it's already floppy, if during the surgery it keeps lateralizing and you're having a very difficult time getting it to stay in a medial position, if in fact you're doing revision surgery and it's clear that the middle turbinate is the problem. For example, the first case I showed you, the middle turbinate was not a problem. The middle turbinate was not the issue. It was sitting in a good position. All the problems were on the lateral nasal wall. The second surgery, the middle turbinate was the problem. It may not have started off being that patient's problem, but it was his problem then. So his revision surgery involved removing part of his middle turbinate. And by the way, that patient also did extremely well after revision surgery. He comes in regularly and continues to do very well and does not have recurrent infections anymore. So I believe the goal is to preserve the middle turbinate if you can, but do not feel like it is impossible to remove or that you should never remove it, particularly if you're having to do revision surgery. Now, if you are going to remove a portion of the middle turbinate, usually the only problem that's a portion that's a problem is the anterior inferior part of the middle turbinate, the head of the middle turbinate, which lateralizes and blocks ventilation of the and access to the anterior ethmoids. So generally, all you're going to remove is the head of the middle turbinate. You're going to leave the superior and posterior portions of the middle turbinate intact. And if I've done a partial middle turbinectomy, it's very easy for me endoscopically to identify the cut edges of the turbinate and still use that as an anatomic landmark. So you don't need to remove the entire thing. You can just remove the portion that is the problem. Another technique, which has been reported by Dr. Bill Bolger, and some people describe this as bulgerizing the turbinate, is to actually either suture the middle turbinate to the septum, across the septum, or actually create a mucosal adhesion by using a microdebrider or an instrument to remove mucosa from the septum and from the medial surface of the middle turbinate, which creates an adhesion between the middle turbinate and the septum, which prevents the middle turbinate from lateralizing. I think that that is a reasonable technique. I personally don't do it that frequently. I'm a bit concerned about the possibility of having too many adhesions between the middle turbinate and the septum, reducing access to the olfactory cleft and causing olfactory problems. I'm also concerned about mucociliary clearance causing crusting and buildup at that spot. Having said that, there's a lot of surgeons who do this, and I've done it myself, and I've seen patients who've had it done who do not have olfactory problems and who actually don't develop mucociliary clearance problems. So it is a reasonable technique. If you really do not want to remove the turbinate, but it's a floppy turbinate, you can create this adhesion between the turbinate and the septum. It's a reasonable approach. However, today, if I saw that situation, I would remove the head of the middle turbinate. I would not do the adhesion, not because it's wrong, it's just my preference to remove the head of the middle turbinate. And also, it's very important that when you reach a point of normal mucosa, leave that intact. You don't need to remove normal mucosa. You shouldn't dissect in undiseased areas because you might create secondary problems, exposed bone, osteitis, et cetera, during your dissection. Also, as I said at the beginning of this talk, always keep in mind that just because the patient had surgery and has now got symptoms and abnormal endoscopy, it may not be that more surgery is the answer. It may be that the patient needs better medical therapy. Maybe the patient needs better topical irrigation. Maybe they need topical budesonide. Maybe they need, maybe they have underlying allergy that's not treated, et cetera. So there is definitely a role for revision surgery, and you can get wonderful outcomes, but not all failures after surgery are due to a surgical anatomic problem. Sometimes it's a medical treatment problem you have to consider. In revision endoscopic sinus surgery, even more than in primary endoscopic sinus surgery, your anatomic landmarks are very, very important, and you need to maximize your use of anatomic landmarks. If you have image guidance available to you, I believe revision surgery is a very good reason to use it. And again, don't believe that just because the patient failed an initial surgery that a revision will also fail. In fact, you can get excellent outcomes with revision surgery. And sometimes the revision surgery can be relatively simple and targeted. It does not have to be extensive surgery in order to be successful. So I want to thank, this is a picture of our campus here. This is our hospital, and this is our medical school buildings here on the Upper East Side of Manhattan in New York City as the sun is going down. And I want to thank Dr. Tarabici for inviting me to participate, and we've definitely got time to answer some questions. So thank you.
Thank you very much, Michael. I guess my question to you, first, if somebody has any questions, please put it on the chat line. And if you want to speak to Dr. Michael directly, please raise your hand and I will be able to open up the microphone. I cannot open up the microphones now because otherwise there will be too much noise. But Michael, just a question. Let's say a patient comes in to see you, had surgery, and you look inside the nose and you do a CT scan, and really you could identify a lot of problems, but the patient is really fine. What would you say, oh, this is going to get worse, I have to do something, or would you say, well, as long as it's fine, I'm fine?
Yeah, that's a really good question. I teach our residents, when they come spend time with me in the office, they're often surprised that I see several patients when you do the endoscopy that they've got some polyps. They've got polypoid change. They don't have a perfect looking sinus cavity. And the resident will say to me, I'm surprised you didn't book those patients for surgery. And I said, well, was the patient bothered? And the reality is there are patients who are doing very well. Their asthma is under control. They're having minimal symptoms. If you look in their nose endoscopically, you will see something you would potentially like to take out, or you'll see an opening that looks a little small. But I don't believe you should do surgery to necessarily, you should do surgery to make an asymptomatic patient better. Because if they're not having symptoms, the question is, why did you need to do the surgery? Now, having said that, there are definitely, and you learn with experience, there are definitely some things you can see on endoscopic exam that even though the patient is not having symptoms now, you know that they're going to develop problems later on. And so I do believe there is a role for changing their medical therapy, for being more aggressive with medical therapy, or even telling the patient that they actually need to go back for revision surgery, even though they're not having a lot of symptoms right now, because It's a simple problem that you can fix now before it becomes worse later. So there is a role for that, but I believe you're treating the patient and their symptoms, and you're not treating their endoscopy or their CT scan. The quality of life and the symptoms is the most important thing. I like to joke about this, but it's actually a little bit true. Patients don't come to you and say, you know, doctor, I'm concerned that I've got an opacified cell. I feel great, but I want surgery because I think I might have an opacified cell. Nobody worries about that. If they feel good, they come in. They come in because they say, I have pressure, I have drainage, my asthma is worse, I'm losing my smell, I'm having recurrent infections. It's that we're treating. We're not treating an anatomic problem that you can see with endoscopy or CT. So I would be careful with making the leap that just because you can identify something, you need to treat it aggressively, either medically or surgically. Having said that, you learn with experience that there are certain findings which predict future problems that you're probably better off treating early. So it's a complicated answer, and I think that's part of the experience that you need to gain. But in fact, I believe that you can have a very successful sinus surgery rhinology practice and see a lot of patients in the office whose endoscopies don't look perfect, but they're much better than when they came in. They're under medical control, they're asymptomatic, and they're doing well. You need to follow those patients, and things might change. But I think that's an important concept.
And in your experience, what is the symptom that brings the patient in most, or the symptom that you think you could help? Like, say, I have this, the sinuses look, you identify certain issues, and what symptoms associated with a successful revision surgery?
So, that's a great question. And I'm not sure there's any one symptom that's necessarily classic in this scenario. I do think that the classic symptoms are going, I want to say one thing though that I want to be very clear about, and that is headache as a primary symptom. I think sinus surgeons need to be very careful operating on patients whose primary symptom is headache. If they have sinus pressure, fullness, which they are describing to you as a sinus headache, and in fact, they have disease in that sinus on scan, I think that's a reasonable indication for surgery. If, however, the patient does not have nasal congestion, rhinorrhea, no change in smell, no cough, they have no other upper airway disease, and all they have is headache, then even the presence of mucosal disease should give you great pause about whether or not surgery is going to treat that patient's headache. In fact, many of those patients actually are primary headache patients. They have an underlying headache syndrome. The mucosal disease that they may have in one or two sinuses may in fact be a trigger for their headache at that moment in time. And you may get a short-term benefit of a medical or surgical treatment of their sinus, and their headache may improve. But I can tell you that headache is going to come back because they're going to have a new trigger. This is fundamentally a headache patient. 6 months or 12 months from now, they're going to get recurrent headaches. And they're going to come back and they're going to say, my headaches are back. I need more surgery. And if at that point they have ventilated sinuses and no evidence of disease, resist the temptation to go do more surgery or do a revision of someone else's surgery if the only symptom is headache with no evidence of obstruction or mucosal disease. There are a lot of neurologic headache syndromes, cluster headache, hemicrania continua, neuralgia, atypical migraines. There's a lot of headache syndromes that will cause sinonasal symptoms, and many of those headache syndromes actually have a vasomotor component. They actually have a component of parasympathetic overstimulation, which causes congestion or rhinorrhea. So patients get headache, and then they get congestion or rhinorrhea, and they assume it's a sinus headache, but the sinus CT scan shows that they don't have sinus disease, and your endoscopy doesn't show it either. So be very, very careful about headache as your primary reason for surgery, and certainly as your primary reason for revision surgery. Those patients need a good evaluation by a headache-sensitive neurologist that is usually what their primary problem is. In my experience, it's those symptoms though. It's nasal congestion, it's rhinorrhea, it's cough, and it's exacerbation of upper air. It's loss of smell in the case of polyps, and it's exacerbation of upper airway disease. It's patients who also have asthma or reactive airways disease whose lower airway disease is worse because of their nasal symptoms. Those are the symptoms which are going to make me much more likely to think that that patient needs revision medical or surgical treatment.
Is regaining the sense of smell, could that be a reasonable objective in your mind to do a revision surgery, or that wouldn't, I mean, you wouldn't think this is a realistic objective?
Yeah, that's a great question. And I think you have to be very careful about advising the patient that you're doing surgery solely for that purpose, because in those patients, first of all, they may have had an inflammatory or an infectious etiology for their loss of smell. So it may not be obstruction of the olfactory cleft. They may have an infectious or other reason. So you can do beautiful surgery and even anatomically restore flow to the olfactory cleft. They're not going to get their smell back. I do discuss with patients who have polyps and obstruction and loss of smell that in fact, they may get their sense of smell back after surgery. And they may get that quality of life benefit, but that's not the only reason we're operating. In fact, even with beautiful surgery, they may not. The other thing is they may get it temporarily, but then lose it in the postoperative period because of persistent edema and inflammation, particularly eosinophilic edema and inflammation, and it may require a lot of extensive medical therapy to regain the sense of smell. So it's important that that not be the primary or the only goal of surgery, but in fact, many patients who have obstructive disease, who have surgery, do regain their sense of smell, and it's definitely worth discussing that with the patient.
Can I ask you to look through the chat line and scroll through it and see if you could, there's quite a few questions.
Yes.
If you could,
Okay, second or third revision, what consent you take in writing, and what do you look for specifically? Well, that's a good question. I don't really, I do the same consent as in, as in initial sinus surgery. I do tell the patient that the more times we go in there, the more chance of, causing a surgical complication with landmarks being removed, entering into the wrong area, of creating scar tissue, and of having problems. And so I tell people that even a third or fourth revision surgery, it's not impossible, but the risk of complications with each revision potentially does go up. So I tell them that, but I still would consent them. I wouldn't consent them any differently. What's my experience? And in CT and MRI, what I'll look for specifically. Specifically, what I'm looking for is the location of mucosal disease. I'm looking for the uncinate. I'm looking for Agarnase cells. I'm looking for anatomic points of obstruction. I'm looking for things like an undissected Haller cell. I'm looking for things like an Anodi cell, a posterior ethmoid cell that's aerated into the sphenoid area, which can fool you because you still believe you're in the ethmoid, but in fact, you're far enough posterior that the optic nerve can be in that cell, the lateral wall of that cell. And so I'm always looking for anatomic abnormalities. Another thing I always look for in the CT scan is I always look for the slope of the fovea ethmoidalis. That's a very, very important point. And in fact, in some patients, that's asymmetric. In some patients, they have a lower fovea on one side than the other. That's a very important point. That's the most common site of CSF leak, is at the middle turbinate attachment of the fovea ethmoidalis. That's the most common site of iatrogenic CSF leak. So that's an area you want to take great care, particularly if that area has already been dissected. That's an area you want to understand what that slope is. And if it's deeply sloping, then you need to be even more careful operating superiorly in the ethmoid. So those are the things I'm looking for. I'm trying to localize the sinuses I'm going to open. I'm looking for anatomic abnormalities. I'm looking for the slope of the fovea. I'm also looking to make sure that the previous surgeon did not do something like create an opening into the lamina propria and that you actually have bulging orbital contents already. That's an important point to realize before you actually go back in and do revision surgery. So that's what I look for. Now, what was my experience regarding underlying causes for revision and how much was, what was the maximum number of revisions in a single patient? Well, in patients with aspirin exacerbated respiratory disease, they have very aggressive recurrent polyps. They tend to do reasonably well in the postoperative period. They like the way they feel. It makes their asthma better. So in fact, those patients often have revision surgeries. I've probably seen 6 or 7 revision surgeries in some patients, although that's unusual. That's probably the maximum. The underlying causes for revision sinus surgery, the vast majority of them, in my experience, are the middle turbinate lateralizing, the uncinate being incompletely resected, or the frontal sinus being inappropriately opened or inadequately opened. So those are the three areas that are the most significant anatomic problems which I have found. Do you experience bulgerizing middle turbinate causes pain? No, I've not seen that. I've not seen it to cause pain. There may be a way I can show this middle turbinate in a diagram. Let me see if I can do. I think there's a way I can sketch on the screen. I'll show how much of the middle turbinate I usually avert. That's a very good question. I actually use the endoscopic middle turbinectomy scissors, the curved scissors, when I do that. How long should we wait before you consider revision surgery? Well, that's a really good question. I think everybody, even revision surgery patients, need a course of optimal medical management. That's sort of a fundamental concept, is that you treat sinusitis medically, and only with medical failures do you have surgery. Even in patients, for example, that first patient I showed, where it was pretty clear that the patient had had inadequate surgery, and the natural opening of the back of the posterior of the, you realize the concept of mucus recirculation, right? The concept there is, if you make a posterior opening into the maxillary sinus, the natural mucociliary clearance moves the mucus to the natural ostium, which is anterior. The mucus comes out the anterior ostium, it travels back in the nose, and it falls into the posterior ostium, builds up in the sinus, comes out the natural ostium, goes back into the posterior ethmoid, because when you make only a posterior opening, you cause this recirculation, and the mucus gets thicker and thicker and thicker and builds up inside the sinus. The way to treat that is to connect the anterior and posterior ostium to make a larger ostium, so that the mucociliary clearance will drain it and it will go down into the nasal cavity. So that was the problem in that patient. But even in that patient, I did not say, you need surgery. What I told him was, I think I see something on your endoscopy that tells me the hole's in the wrong place. And I think what you're going to eventually need is revision surgery. However, let's try you on some optimal medical management. Let's make sure your allergies are treated. Let's put you on a mucus thinning agent, guaifenesin, I put the patient on. Let's have you do some irrigations for a period of time. Let's give you a few weeks of treatment and see if you can get this postnasal drainage to clear up medically. If you can, that would be great. I didn't have high anticipation of success or expectation of success, and sure enough, the patient improved only a small amount. So at that point, he was frustrated. He had failed medical therapy, and I went to surgery. But I always will put the patient on, I'll try to optimize their medical management before I go back to surgery.
I'm surprised by your choice of medical management. This is all what you do? You don't give like a course of oral steroids?
Oh, that's a great question. No, in that particular patient, it appeared he had thick mucus recirculation. So that's what I gave that patient. No, oral steroids in many patients with polyps, polypoid edema, inflammatory disease, oral steroids, topical budesonide I use very, very frequently as a much more effective way of getting topical therapy. And absolutely, no, that's not, it's depends on what the underlying etiology is. If it's infectious, I'll give the patient antibiotics. I find in my practice, it's a minority of chronic sinusitis patients who actually have primary infection as their etiology. It's really a primary inflammatory process in the majority, not 100%, but the majority of patients. But in that patient, I did not treat him with, for example, oral steroids, but I would use that frequently in cases of recurrent sinusitis that need as a medical treatment before sinus surgery.
So going back to the dam middle turbinate, do you see any, I mean, do you think that the middle turbinate obstructs the administration of local medication into the sinuses? I mean, do you think that could be a reason for taking it out?
In some patients, yes, absolutely. Particularly if it's lateralized or there's a pretty significant synechia there. I think the presence of the middle turbinate, if the patient is doing irrigations, by the way, it's been established pretty well that the best technique for getting adequate mucosal penetration and contact in the maxillary and ethmoid sinuses is high volume liquid. It's not spray, and it's not aerosol, and it's not nebulizer. Nebulizer is a great concept. It seems like if you nebulize it and inhale it, it will get in farther. But studies have actually shown that high volume liquid with the medicine dissolved in the liquid is the best way to get it in. In my experience, if the turbinate is just sitting there, but there's an opening into the ethmoid sinus, into the maxillary, the turbinate itself is not going to block the access of topical irrigation into the sinus. If the turbinate is lateralized and completely blocking access, it can. But so I don't routinely remove it to allow better access. But if the turbinate's in the way, I remove it. And I do believe in many cases, the anterior turbinate, the anterior aspect of the middle turbinate is really the problem. Since revision surgery tends to have fibrous tissue formation, is there a rational manner to give systemic medication to prevent it? Yeah, it's a great question. So yes, the more times you go back in and do surgery, the more likely it is you're going to get scar tissue, the more likely you're going to get fibrotic tissue. So I do typically give patients a short course of oral steroids, a short course in the postoperative period, and also healing is basically controlled inflammation. The body creates, sends the cells to create the fibroblasts for healing by using a controlled inflammatory pathway. So in fact, the healing process inside the sinus in a patient who is a polyp former will often cause recurrent polyps. And this is a point that I should have made earlier. You will see recurrent polyps in the healing sinus cavity of many patients in the postoperative period. And they typically occur between 3 and 8 weeks. That's a period when you'll start to see polyps. That does not mean your surgery's failed. That does not mean that the patient needs revision surgery. In that scenario, give the patient a course of oral steroids. That is simply a dysfunctional inflammatory response to the healing, to the normal healing process in the majority of patients. It doesn't mean that they have recurrent infection or that they are heading back to recurrent polyps. And in most patients who get that polypoid change in the healing sinus cavity between 3 and 8 weeks, they will respond very nicely to 7 to 10 days of oral steroids. And when they reach the next phase of healing, they won't get recurrent polyps. So don't panic, don't give up when you see recurrent polyps at that point in time. Give the patient oral steroids. Let me see if I can show here a, I thought there was a way to do a
Yeah, the board,
drawing.
Whiteboard, you have to use a whiteboard.
I'm not seeing whiteboard here as an option for me.
Maybe, 1 second, let me see. Enable, wait, no.
I'm not seeing it as an option.
Yeah, I understand, you're right. Share screen. Well.
I can go back to one of my slides, I think. And,
yeah, please go ahead.
And demonstrate that. All right. Okay, this dotted line here is basically the shape of the middle turbinate, okay? I will make my first cut about right here. I am attempting to leave a good portion of this superior vertical portion of the turbinate. I'm trying to remove the bulbous head of the turbinate. I'll make my first cut right here. I'll make 1 second cut with the depth of the endoscopic scissors back, and then immediately I will start turning down. I'll turn my scissors down. I want to leave most of this posterior part of the turbinate intact, and I want to leave the superior part. So the portion I'm removing is basically this much. That's the portion, I should say about right there. That's the portion that is going to lateralize, that's going to block the maxillary osseous, that's going to block the anterior ethmoid. This posterior part, generally, first of all, it's not so floppy, particularly if you've got this horizontal strut in place. And I don't think there's any value in removing this entire turbinate all the way back. Plus, the farther back you go, the more likely you're going to get into branches of the spina palatine, and it's going to bleed. And you're going to get postoperative bleeding. You do need to cauterize the stump of that turbinate posteriorly pretty well, because that is a source of postoperative bleeding. If you just cut that turbinate and don't cauterize that stump, because there's vessels, branches of the spina palatine that are running in that area. That's basically all I remove. So I think of myself as removing the head of the middle turbinate, and it's probably 1/3 of the total size of the turbinate. That's what I try to remove.
Have you noticed any association between cauterization and delayed bleeding? Like bleeding 2 or 3, 1 or 2 weeks later?
You mean that if you cauterize, they have an increased chance of that?
Yeah.
No, I've not seen that. Have you seen that?
It is my experience actually in the area of the sphenoparatine. I've noticed that if I do aggressive cauterization, 2 weeks later you get this really unbelievable bleeding. Maybe when the scabs comes off, and I've owned, it happened when I was doing a lot of cauterization and stopped when I stopped, but it could be just a random observation.
Well, that's interesting. No, I've actually not seen that. The thing that I have seen is um, um, that area, because of all the vasoconstriction during surgery, you don't recognize that, and the patient gets a bleed in the postoperative period, the first couple days post-op, if you don't do a good job of cauterizing that stump. When I say cauterize, I typically will use the bipolar, the endoscopic bipolar cautery. I don't use the suction cautery. I think it creates a more precise area of cautery. Certainly, it's theoretically concerned that as that scab separates, you could still get bleeding. I just have not seen that.
Oh, thank you very much.
Absolutely. Thank you for the invitation. Thanks everyone for being here. Very nice attendance, and thanks for all the questions.
Great. Thank you. Take care, Michael.
Bye-bye. Thanks, Boaz.
Thank you. So basically, I'm going to share with you the what's coming up in the next few days, the rotating slides. And thank you for being with us, and hopefully we'll see you tomorrow. Thank you.